So, very good afternoon, everyone. It gives me great pleasure to welcome all of you to today's KidsToxLK Pediatric Poison Information and Research Center webinar. And on behalf of the organizing team, I extend a warm welcome to our distinguished speaker, Ms. Lucy Shieffelbien, and to all the participants joining us from across Sri Lanka and beyond. Ms. Lucy Shieffelbien is a highly respected figure in the field of toxicology and poison information services. She has been the service delivery manager of the New Zealand National Poison Centre since the year 2001, bringing in her expertise over 3 decades in healthcare service delivery. And her career has been marked by a deep commitment to improving the accessibility and the quality of the poison information services, not only within the New Zealand, but across the Pacific region. Lucy has played a pivotal role in establishing Poison Information Network that now connects 5 Pacific Island nations, a remarkable initiative that has strengthened regional capacity, enhanced toxicology expertise, and ensured timely expert guidance for healthcare professionals managing poisoning emergencies. And through her leadership, Lucy has helped raise the standards of poison management and emergency response, particularly in settings where the resources and expertise are limited. Her work has had a lasting impact on public health outcomes, especially among the vulnerable and remote communities. And beyond her national and regional contributions, Lucy also serves on the board of the Asia Pacific Association of Medical Toxicology and also a valued member of the Toxins Steering and Advisory Group. And in these roles, she continues to influence the development of toxicology services and knowledge sharing networks across the Asia Pacific regions. So today, we are honored to have you with us. And so your perspectives will be invaluable as we are at the KidsToxLK continue to strengthen the pediatric poison information and research efforts in Sri Lanka. So please join me in welcoming Ms. Lucy to deliver her presentation. Over to you, Lucy.
Thanks. Thank you, Kavinda. I'll just quickly share my screen. Can you see my presentation? Is it loaded?
Yeah, we do, Lucy. Yeah,
That's
great.
Just trying to put it into presenter mode. It's just not quite. There we go. Okay, right. Thank you, everybody. Sorry about all that. So, as Kavinda said, I'm from the New Zealand National Poison Centre, and I'd just quite like to give you an overview of the kinds of poisonings that we deal with in children in New Zealand, particularly in relation to household products. So I'll talk about our experience. First of all, just talk about the Poison Centre in New Zealand, who we are, what we do, a bit about how long we've been around for, and then look at some examples of legislation that we've actually got in New Zealand that help us try and keep children safe. So fortunately, we've got some really good laws around poisoning, which helps prevent some. Then I'll go through some actual numbers from 2024. And then I want to talk about toxicovigilance. So what is it we do when we recognise that a child, there's been a cluster of childhood poisonings or there's a substance of concern? How do we manage that? And then hopefully we'll have some time for some questions. So the National Poison Centre is actually based at the University of Otago in Dunedin. So it's part of the Division of Health Sciences. And it started operations in 1964. So we've now been around, this is our 61st year. So what do? We're there 24/7 and we answer calls about the toxic effects of medicines, chemicals, animals, plants and fungi. And those calls come from both members of the public as well as healthcare professionals. So we're the only poison centre of its kind in New Zealand. We serve a population of around about sort of 5.5 million people. So there's only one poison centre, unlike Australia, for example, that has one, or multiple centres in different states. There's only one in New Zealand. And like I say, we provide freely accessible healthcare advice 24/7. So we're funded as part of the National Telehealth Service. So the National Telehealth Service brings together all the telehealth helplines in New Zealand that are funded by the government. Currently, there are 35 different services operating as part of the National Telehealth Service. That covers everything from mental health, addiction, poisoning, just general nursing advice, for example. So there's just an overview of some of the lines that are part of that telehealth service that are all bundled in together. So you can see their quit line for smoking, gambling, elder abuse. It kind of covers everything, really. So I just want to touch on what the value of a poison centre is. So fortunately, a lot of paediatric poisoning incidents don't actually result in significant harm. A lot of them are quite innocuous, but often parents are looking for that reassurance. It's a legitimate reason for seeking advice and reassurance to know that their child is going to be okay. So what would happen if the poison centre didn't exist? Suddenly, I think our hospitals and our ambulance services would certainly be overrun and overutilised by people seeking help and guidance, particularly with paediatric poisonings, because it can be a very frightening time for a parent when they're uncertain of what's happening with their child. So it's our goal to try and treat as many patients or as many poisoning cases as we can by keeping them at home, but only when it's safe to do so. So if someone needs to go to hospital, we do refer them in, but ultimately we try and keep as many cases away from hospital as possible. During COVID, because we didn't know what the sort of impact on the hospital would be, we actually modified some of our triage guidelines and actually extended them slightly further. So where we would have perhaps sent somebody in for, say, an eye exam, if it wasn't, depending on the substance, we would keep them at home because we knew that we didn't want the hospitals to be overrun. So about 75% of calls to us are managed at home. So that's quite a few. In terms of getting advice, 80% of our calls are answered within 20 seconds. You're certainly not going to get a response from a hospital within 20 seconds. And the average time it takes to call the poison centre, get a risk assessment done, have the advice that you need is less than 5 minutes. And if you look at the cost of providing that, it's roughly about 60 New Zealand dollars per call. Compare that to the cost of an emergency department visit or an ambulance, which can range anywhere sort of between $500 to $1,500, again, New Zealand dollars. And you visit the emergency department, you could be there for hours. If you're wanting, say a paracetamol blood level done, or you find that you don't even need to be there, you wait there 6 hours to be triaged to find that you can go home again. So the financial cost aside, just the burden it would be just enormous to the health system. So 5 minutes versus 6 hours, $1.6 million to run a poison centre versus $162 million to run an emergency department. Having a poison centre is actually a really, really wise investment, and it does save the government money. So our poison centre in New Zealand is not big. We only have 15 staff. So we've got our director and deputy director, who are both medical toxicologists. There's myself. We're supported by 3 part-time on-call doctors from around New Zealand. So if either of our 2 medical toxicologists are stay travelling and they can't be available to provide on-call advice, we do have 3 part-time doctors that step in and help out. We have 2 poisons information specialists, and they support the team of 9. So we only have 9 people that are answering the calls 24/7. And that's about 27,000 calls a year those 9 staff answer. And we also have 1 person who's a research fellow, and she's our data guru. So there's just a wee insight. That's our actual poison centre. There's the actual call centre there that we work in. It's quite a nice wee setup. So does anyone want to have a think about what do you think would be the biggest cause of childhood poisonings in New Zealand? Paracetamol. Good old paracetamol, both liquid and tablet formulations. And last year in New Zealand, we received 1,344 paracetamol exposure calls, and that includes combination products, of course, relating to children under the age of 14. So that's on average 3 to 4 calls that we get every day about children ingesting paracetamol. So why is paracetamol the biggest cause of childhood poisonings in New Zealand? One of the common things is incorrect storage. People don't appreciate the fact that it's actually, can be quite dangerous. And so they don't leave it out of reach and out of sight of children, or they don't put the child-resistant closure back on properly. Often it's a case of therapeutic error. So that could be anything from they've given the wrong dose, the wrong formulation, they've given it too often, for example. Sometimes mum will give a dose and forgets to tell dad, then dad gives a dose, and we've got suddenly double dosing, or grandparents will give a dose and not say anything. One of the biggest issues we have in New Zealand as well is GPs will often prescribe like a litre of paracetamol. Excuse me. If you have a sick child, chances are that all your children are going to get sick. So the doctor quite happily will prescribe you this very large bottle of paracetamol. Now, unfortunately, the prescribing label has information for the person that it was prescribed for at that time, on that day, for a certain condition. Now, as we all know, paracetamol is the dose is based on weight. So if you've got a 5-year-old child, for example, that it's been prescribed for, and then your 18-month-old toddler gets sick, it's all too very tempting to then take that bottle of paracetamol, try and work out the dose that your 18-month should have, and give it to them without appreciating the fact that it's actually weight-based. So that's where things can go wrong as well, and we get therapeutic errors happening. And like I say, accessibility, you can walk into a pharmacy and buy liquid paracetamol. You can buy tablets of paracetamol in the supermarket. It's freely accessible in a lot of stores. So it's probably quite prevalent in most homes throughout New Zealand. So what are some of the other causes of childhood poisonings in New Zealand? Household chemicals. So anti-infectives, good old bleach. Your detergents, so they're generally like your dish liquids and things that often people will keep under the kitchen sink. Cosmetics, laundry preparations, not just the laundry detergents, but often things like soaking agents. So you might have a bucket of nappies soaking, and so it's quite accessible to a child to get into the liquid. Calls about plants and fungi. The most common call in terms of plants, the most common plant we get called about is the one that has green leaves and red berries. Unfortunately, that could be any plant. There are so many plants that have green leaves and red berries, but you'll be surprised how many people ring up and that's how they describe the plant to us. So it's one thing we're very particular on, is we ask people to clearly identify the plant because we don't want to get the information wrong. And another common form of poisonings is insecticides and pesticides, particularly things like ant baits, rodenticides, for example. They're quite often, at child sort of floor level. So as I mentioned, we've got some bits of legislation in New Zealand that we have that are specifically designed to try and keep children safe from poisoning. First one comes under the Food Safety Regulations of 2002. And this is in relation to misuse of food containers. So in New Zealand, it's actually illegal, and you can be prosecuted in a court of law for storing a chemical or other like substance in a food or beverage container. So this is the actual legislation here, which says no person may put, keep, or sell any disinfectant, antiseptic, or detergent or a substance that could cause poisoning, so that sort of covers it all really, in any container or package that bears a brand, picture, word, mark, or statement indicating the presence of in the container of any food. It also pertains to beverages as well. And you'll be surprised how many people will, decant some petrol from the lawnmower, for example, into a Coca-Cola bottle. You say to them, well, why did you do that? And they go, well, I wrote on it says petrol. Well, that's fine, but 3-year-olds generally can't read very well, so there's no point writing on it. It's just not going to help the child. So that's just, again. So back in 2012, there was actually a case in New Zealand where a cleaner at an establishment in Auckland had decanted some cleaning fluid. She cleaned the toilets, decanted the leftover cleaning product into a Sprite bottle, and she left it on the bar in this establishment. Next day, this lady was celebrating her 73rd birthday when she was served the chemical, which turned out to be benzalkonium chloride. Because it's clear, it doesn't look like Sprite, the bar staff, they didn't think anything of it. Because it had been left on the bar, they inadvertently picked it up, put it in the refrigerator. The next day, served it to this lady thinking it was lemonade, thinking it was Sprite. She quite quickly became quite ill, and she was hospitalised with burns to her throat and esophagus. She also had a friend with her, and she sort of said, oh, this lemonade doesn't taste right. You have a taste. So her friend drank some as well. So she was also hospitalised. Why did that happen? As I said, the cleaner had decanted some chemical into this bottle. Staff member didn't think anything of it, put the unlabeled bottle into the refrigerator with the other drinks, and then served it to a customer. Now, both the cleaner who put the chemical into the Sprite bottle and the establishment that served it as a drink accidentally were both charged under the food safety regulations and pleaded guilty in a court of law. The cleaner, unfortunately, she was given a written warning. She retained her employment and was ordered to pay costs to the victims for harm. So one of the things it did do is it promoted a nationwide review of cleaning and bar procedures amongst this group of establishments and highlighted the dangers of storing chemicals in food and drink containers. We get quite a number of calls each year from children consuming chemicals out of things like Powerade bottles and Coca-Cola bottles. Another piece of relevant legislation is what's called HAZNO, the Hazardous Substances and New Organisms Act of 1996. Now, when any time a manufacturer wants to import or sell any kind of chemical in New Zealand that comes under this piece of legislation that potentially is toxic to humans, there are certain things they have to do. There's bits of legislation they have to abide by. One of those things is they must provide on the packaging, on the label, and on the safety data sheet, a 24-hour emergency contact phone number where people can obtain information, in particular in relation to first aid or medical advice. So that's anywhere where any of the substances that they're selling are covered in any of these classes. So most of them for human will come under acute toxicity, skin corrosion, irritation, or serious eye damage. So by law, they're required to have that information on their product. They can choose to have the phone number for the poison centre. Now, if they do that, they have to seek our permission to use our phone number. And in return, they are required by law to lodge a copy of the safety data sheet with the poison centre. Now, prior to this legislation, this was introduced in 2017. Prior to that, often manufacturers would put our phone number on their product. So you buy a bottle of bleach and it says, if ingested, ring the poison centre. Well, bleach is probably not a good example because everybody knows what's in bleach. But for example, if they've got a product that they're selling, maybe a laundry detergent, for example, people would then phone us because it says to on the label, and we would have to try and work out what's in the product. So what has this child been exposed to? And when you'd say to the caller, I'm not quite sure what's in this product, and they'd say, but it says here on the label to call you. So fortunately, in 2017, it became law to supply that safety data sheet. So that's great for us. We now have hands-on information. So if a child is exposed, we know straight away what we're dealing with. And it's actually quite a good, we haven't actually done this yet, but it is actually potentially a good way of funding the poison centre because we could actually start charging manufacturers for lodging those safety data sheets because there is quite a bit of work involved in keeping a record of all those products. So here's some examples. Here's some bake blocks. And on the back is all the use instructions and ingredients and things. And if we zoom in there, it says first aid, if swallowed, do not induce vomiting, seek medical advice, or contact the National Poison Centre, and it has our phone number there. Now, if a child ingests, bites into one of these bake blocks now, and someone phones us, we can look up Kiwi Care, no rats and mice, and know exactly what's in the bake block and give the appropriate advice based on the ingredients. And so it doesn't just specifically relate to chemicals and household products. So here's some examples. Here's some insecticides, so some fly spray. Once again, it has on the back, if sprayed on the skin, wash thoroughly. If poisoning occurs, contact a doctor or the poison centre. And there's the phone number again. Cosmetic products. So here's some hair dye. Because it falls under that HAZNO, Hazardous Chemicals and New Organisms Act, it's still required to have information on the label. And again, it has information on how to contact the poison centre. This one actually is quite good because it has a bit of information on how to flush an eye, for example. Active, so this is your automatic dishwash tablets for dishwasher machines. Again, how to use, but more importantly, first aid information and to keep out of reach of children and contact the poison centre if someone does swallow it. Also, it happens with therapeutics. So here's some paracetamol packets. And again, amongst the dosage instructions, it does actually say, if an overdose is taken or suspected, ring the Poisons Information Centre, and it has the phone number there. This product is sold in both Australia and New Zealand, so it's got both phone numbers on there. Voltaren Imugel, same thing again. In the package insert inside the product, it has the phone number for both poison centres. And then animal remedies. You'll be surprised how many parents will use animal remedies on their children. So, for example, head lice. They'll use an animal product to deal with head lice, instead of buying human products. Anyway, on the packaging, again, there we go. If poisoning occurs, contact the poison centre. So just going through now some, looking at our records for the past 12 months. And this is for all calls. So this is not just specifically related to children, but I'll just give you an overview of the number of calls that we do get. So last year we answered 23,423 phone calls. So that's how many phone contacts we had at the Poison Centre. And 24,000 of those related to human patients with substance exposures. We do get quite a few calls with people with their pets, their puppies are eating something, or their cat's gotten, had some, drunk some antifreeze, let some antifreeze from under the car, for example. As I was saying before, we get calls from both members of the public and healthcare professionals. So last year, nearly 4,500 calls came from medical professionals, from ICUs, from emergency departments, primary care, general practice, for example, ambulance officers. They're all come under that 4,500. We also talk about, so even though we had 27,000 contacts, this is where it gets confusing when you're doing data, and this is why our data guru is just so fantastic. You can have a contact, which is different to a case or an exposure. So you might have one phone call, but it might involve two patients, for example. So that's potentially two exposures. Or you might have one phone call regarding one patient, but multiple substances. So again, we consider that to be multiple exposures, but only one contact. But of all those records last year, those 25,600 records that we generated, 40% of those, so just under half, involved children 0 to 5. 86% of those exposures occurred in residential settings, 2% in schools, and 4% in a workplace environment. And 80% of records involved on-site management without further medical referral. So basically, we could keep them on-site, whether that was at home or in the workplace, or whether that was at school. Basically, what we didn't need to do is we did not need to send them to a hospital or a medical facility. And we also do customer satisfaction surveys. So 98% of our service users were satisfied with the service we gave them. So just looking here, this is an overview. It's quite a complex graph here, but this is looking at our record numbers by age group for all human exposures. And if you look at the first two columns there, 45% of those human exposure calls involved children under the age of 12. And as I said before, nearly 40% of those were under the age of 5. Age and reason for human exposures, 84% of human call exposures last year involving children under 5 were child exploratory, which goes, makes sense. Children are great at getting into things, and that's the prime age for exploring and crawling and tasting and touching. So 84% were as a result of child exploratory in the 0 to 5 category. So you'll see there where we jump up to the 6 to 12-year-olds, only 38% of that behaviour was to do with child exploratory, because we'd like to think that by the time a child has sort of reached 10 and 12 years of age, that they're past that getting into things phase. Location of exposure, as I said, 86% happened in a residential setting. Now, this is not the whole year. I just take a wee chunk here. This is the last quarter of 2024. And the breakdown I've got here is looking at the three main categories of therapeutics, household products, and miscellaneous, and then by age group. So you'll see there again in the top row, the 0 to age 5 group. Therapeutics was the biggest cause of concern, followed by household. So we had, 48% of calls involving 0 to 5-year-olds involved some sort of therapeutic substance. Why? Again, therapeutics, child exploratory, compared to therapeutic era, which is another one. Well, you'd like to think that if it's a therapeutic era, it must have involved therapeutic substance, but not always. Some people sometimes confuse, their pet's medication for their medication, so it's not necessarily a therapeutic substance in that case. This is the outcome of all the calls. So in all the calls that we received in the 0 to 5 age group, you can see there that no require any further medical referral. A few of them required further information, but most of them are stay at home. Very similar with the 6 to 12-year-olds, no further medical referral was advised. There's the 13 to 19-year-old age groups. Once they get to that age, they do tend to sort of require intervention. Often it can be because it's a self-harm, even if it's... So if we had a call involving a 16-year-old, for example, who said, I ate a whole bag of gummy bears because I wanted to hurt myself. Well, the gummy bears aren't concerning, but it's the intent behind why they wanted to do it is why we would refer them in. And so they would automatically be referred in for a psychiatric assessment. And that's just looking at the 65 plus age group. So reasons behind exposures in children. So we've got the 0 to 12 and 0 to 5 and 6 to 12-year-olds. Again, child exploratory, unintentional. So therapeutic error is quite high there for children in both age ranges. And again, we define therapeutic error as incorrect substance or patient, incorrect dose or frequency, or other therapeutic error. Fortunately, the self-harm calls, we didn't receive any self-harms. We didn't have any 0 to 5-year-olds ring up saying they wanted to harm themselves. It's a relief. Unfortunately, we had a couple of calls. There's 6 calls in the 6 to 12-year-old age group, which is a bit of a concern. So if we look at the classifications of products, we classify them into different kind of groupings. So the top 10 non-medical chemicals ingested by children last year, 0 to 12. The top one, household miscellaneous. Now it's just a broad dumping ground, really. That's where anything that doesn't fit anywhere else gets put into the miscellaneous category. Or it might contain things like silica gel. So silica gel we get a lot of calls for as a non-therapeutic or household product. And silica gel, as you know, it'll have on the wee packets, do not eat. And it's not because it's toxic, as we know, because it will remain inert and pass right through, but it's the choking hazard. But because it has on there, do not eat, parents assume that it is toxic and they do phone us, and we do get a lot of calls about silica gel. Followed closely, like I say, by plants, cosmetics. Cosmetics, people leave them in your handbags, so they're quite accessible to children. They'll be in the bathroom counters. Again, not necessarily locked away, so children like to explore. Household cleaners, so that's typically your non-detergents, but your surface sprays, for example, your surface cleaners, glass cleaner, that kind of thing. 6, anti-infectives, so that's your bleach and your sanitizers. 7 is your household detergents. 8 is insecticides. Like I said, 9 is your laundry preparations. And the number 10 category is industrial products that are found lying around the home. Here's a list of top 10 therapeutic agents that are ingested by children in the 0 to 12 category. As I said, paracetamol and combination products is the number 1 therapeutic agent, followed closely by ibuprofen and its combination products. Then we have a lot of herbal or complementary medicines. Parents seem, for some reason, tend to give their children lots of vitamins and vitamin gummies and things like that. Obviously, they don't see them as being particularly nasty, so they don't take precautions to keep them out of reach of children. Obviously, if they've got iron and things in them, that's when they become a bit of an issue. But traditional medicines, complementary medicines, homeopathy remedies, that sort of thing, that all falls in that herbal number 3 category. Going down, you can see this kind of changes a wee bit too. So like loratadine, Amoxicillin, again, so it depends on the time of year, how many allergies and colds and flus and things are around, for example. So that list can change, but not too much. These are the substances, are the top 10 that did require medical referral in children 0 to 12. And you'll see that again, paracetamol stands to reason. But number 3 on the list is nicotine. And that includes not just cigarette butts, but also NRT, so nicotine replacement therapy. It was really interesting. In 2010, the New Zealand government decided that it wanted to work towards making New Zealand smoke-free completely, so completely illegal to smoke. It was meant to be, the goal was 2025. So in order to achieve that, they started putting an increase in tax on cigarettes. Every year on the 1st of January, the price of cigarettes would increase and the amount of tax being collected by the government would also increase. Now, as a result of that, start of January, price of cigarettes goes up, people decide they're going to quit smoking, so they would ring Quitline. Then our calls would go up. And it took us a while to actually appreciate the fact that when someone phones Quitline and they're given nicotine lozenges, for example, or gum, they don't actually appreciate that it's actually quite toxic and they'll just leave it lying around. And of course, children cannot decipher the difference between confectionery gum and therapeutic gum, for example. So we had this every year, the start of the year, children ingesting quite huge amounts actually of nicotine type products. One year we had a small child who ingested 15 pieces of nicotine gum. And when I flagged that with the ministry, the person I spoke to sort of said, oh, we can't even get adults to tolerate chewing one piece of gum. Why would a child eat 15? But as we all know, children don't have particularly well-defined taste buds, so they're quite happy to put all sorts of things in their mouths. Looking down the list there, obviously we've got some cardiovascular medications, lorazepam, melatonin. Again, it was on both lists, but obviously at doses high enough that it's going to require medical referral in this instance. So what do we do with all this data? It's fine and dandy to be the ambulance at the bottom of the cliff and provide advice when children are poisoned, but how do we stop them from being poisoned? What can we do with all this useful information? So this is what we call toxicovigilance. And so that's where we actively survey all our calls relating to not just children, but all our poison calls, and look for trends, for patterns, anything of concern. Often that's how we know when there is a new consumer product on the market, because suddenly we start getting calls about it. When there's a product, I'm not sure if you have it in Sri Lanka, it's called Duck Fresh Discs. And basically it's a toilet bowl freshener, and it comes in a wee tube, and you plunge the substance onto the side of the toilet bowl. So every time you flush the toilet, it just gives off this supposed, nice fresh aroma in the toilet. Unfortunately, because when you plunge the wee discs onto the side of the toilet bowl, they're quite attractive to children. They look like lollies. So when they first came on the market in New Zealand, we were inundated with calls for children picking these, things out of the toilet bowl. Again, not exactly toxic, so they're quite low risk, but they're very viscous, so they present quite a choking hazard. So we don't really want children ingesting them. So we hadn't heard of this product until, lo and behold, in this society of consumers that we are, we're very driven on buying new products. We like to try new things that come out of the supermarket. So obviously there've been quite an uptake of these products, and as a result, children were ingesting them. So that's how we heard about them. So here's a case example back, going right back to the 1990s. We were seeing lots of children being harmed from dishwash powders. When I say harm, these children were getting significant corrosive burn injuries and esophageal burns, requiring, hospitalisation in some cases, surgical intervention. And so it was such a concern to us that we began raising it with the Ministry of Health, saying, look, this should not be happening. These children are being harmed, and it's in particular with dishwash powders. And you can see there that wee picture I've got of that wee girl. And this is one of the common scenarios, is when the mum's busy unloading the dishwasher, And of course, the child's playing with the dishwasher, and you've got the wee dispenser thing there. And sometimes the powder doesn't always dissolve, or it's not always fully dispensed. And you can end up with a dishwash sort of powder sludge in that wee dispenser. And you can see there she's got her wee fingers in there, and then the fingers are going to go into the mouth. And before you know it, she's ingested a wee handful of corrosive dishwash powder. So it's quite a common way children get injured. So despite most containers having child-resistant closures on them, which is part of the legislation, children are still being harmed. So we raised this time and time again with the Ministry of Health as well as Ministry of Consumer Affairs. But we were met with, thank you for your concern. Yes, your email has been received. Yes, your concern has been noted, but nothing ever changed. And it was quite frustrating, but we kept reporting. We just kept on going. And then in October 2004, everything changed. And that's because this wee chap here, little Joshua, at the time, he was incorrect date there. It should be 2004, not 2024. He was a wee 19-month-old toddler. And he received such significant burns that by the time he was 4 years old, he'd endured more than 44 surgical procedures. And it was mostly to remove scar tissue from his upper airway. He ended up with a feeding tube and a tracheotomy. And his poor mother, would have to get up, anything up to sort of 10, 15 times during the night to suction him to make sure he was, his airway was clear. So that shows you what a horrific injury that wee boy suffered. How did it happen? It all happened so fast. The family just moved into a new house, and they'd never had a dishwasher before. So this was quite a novel appliance for them. Joshua's mum, Lara, she put the dishes into the dishwasher. She put the powder in, shut the door, and started the machine going. And she put the bottle of dishwash powder up on the bench, thinking, well, that's high enough up. The kids can't get into that. They can't reach. It'll be fine. Not appreciating, how toxic it actually is. And because it was up out of reach of the children, it sort of gave her this false sense of security. So she didn't actually engage the child-resistant closure that's on the bottle. If you don't sort of make it click into place, then it's not actually on, so it doesn't actually serve any function. Lara went into the bathroom. She'd only been gone a minute or two when she heard her other child shouting that little Joshua had been in an accident. She came racing out to find him lying on the floor next to his little plastic ride-on motorcycle. And what he'd done is he'd dragged his little tricycle over to the bench, climbed up onto the tricycle. He'd managed to grab the bottle of dishwash powder, pull it over, and because the lid was not actually clicked on, the lid just came straight off. He lifted it up to his mouth, and because it was a brand new bottle, just the sheer weight of the powder basically forced its way down its throat. So as soon as you tilted the bottle, with the help of gravity and the weight of the powder, it had no chance. So by the time his mother had come out, first of all, when she saw him lying on the floor, she just initially thought that he'd fallen off his tricycle, his little motorbike. And it wasn't until she saw that, he was vomiting and foaming and that there was blood dribbling from his lips that she knew something was really, really wrong. And that's when she realised that he'd climbed up and managed to get the dishwash powder. Not realising initially the full extent of her son's injuries, because she could only see externally, like the blood and stuff. She didn't realise internally what was actually going on. Her first instinct was to just put Joshua in the car and drive him to the doctor. Now, you recall before I said average call time to the poison centre is about 5 minutes. So in the time it would have taken her to find her car keys, put little Joshua into his car seat, back the car out the drive and start driving to the hospital, she could have phoned us, and in this instance, we would have advised ambulance straight away. But if it was a less significant poisoning, the parent would have had the information. We would have done a risk assessment, and they would know what they were dealing with and the time it takes them to even back out the drive. Once Joshua started to have difficulties breathing, Lara knew that she was in trouble. She knew that Joshua's injuries were quite significant. At that point, she just still had him cradled in her arms. She just ran down the road basically screaming for help until a neighbour came out and phoned an ambulance for her. Little Joshua spent 3 days in intensive care and a medically induced coma. And basically it changed the life of that whole family from that day on, because for the next however many years, their life revolved around hospital appointments and surgeries and rehab and speech therapy and feeding tubes, and it was a completely different life for them. They had to adjust to this newfound life they found themselves with Joshua. All of a sudden, somebody at the Ministry of Health did what we call a quick back of the envelope sort of calculation, and they worked out that Joshua's care was likely to be in the cost of around $4 million. And of course, governments don't like spending money, and when they discover that one little boy, that one little poisoning is going to cost them $4 million, suddenly they sat up and paid attention. And almost overnight, the law was changed in New Zealand. In that case, little Joshua became the catalyst for the government banning the sale or manufacture of dishwash powders that contained a pH of over 12.5. And you know, from that time on, so from July 2007, we very rarely see any esophageal burns now in relation to dishwash powders in children. Yes, children still get into them. Yep, they always will, because as I say, children like to explore, but at least they're not being harmed like they were. We're not seeing those, we're not sending kids off for endoscopies because, it's like they've had a taste, they've spat it out. It didn't actually, might have hurt a wee bit, but it hasn't left them blistered and burnt and scarred and gagging, and it's just not happening. Now, that little boy, he should not have been the reason the law was changed. That law should have been changed because we were telling the government that he was, this is likely to happen. There's risk here. A child is likely to be harmed significantly. But they chose not to listen, continued on, and this was the outcome, unfortunately. And, through toxicovigilance, that's the idea of doing toxicovigilance, is we can be that warning beacon to the government and to government agencies. And whether it's the Ministry of Health or whether it's a consumer-type product, having our data there, we currently use toxicovigilance as well for illicit drugs. So we work with the policing agency called High Alert. That's the name of the website is High Alert, but it's run by the Drug Enforcement Intelligence Agency of New Zealand in conjunction with New Zealand Police. So we contribute our call data to their surveillance system, and we actually have a real-time surveillance tracking system. So we can see where the hotspots are, and we can see what kind of harm is coming from different illicit substances. We know if there's been, for example, a festival on and someone's had some MDMA and it's been adulterated. So that's the sort of information we can share, and that's where toxicovigilance has its value, but only if those that you're giving that information to heed the warnings and actually act on that information you're giving. So here's just looking back, so talking about the dishwash powders. So in the 2-year period leading up into that law change and leading up into where Joshua was hurt, here's the kind of calls that we were getting. So in that 2-year period, we'd received 610 dishwash powder ingestion calls. 88% of those were in children less than the age of 2. Now, we all know that children of that age are still crawling, so they're the ones more likely to get into the sludge and the dishwash drawer. So it makes sense that, that's 2-year-olds would be the biggest category there. During that period, 23 of those children had to be admitted to the Children's Hospital in New Zealand, Starship Children's Hospital, following the caustic ingestion. And of those 23, 11 were positively identified as having ingested dishwasher. 9 boys, 2 girls. Not sure why boys tend to get into things more than girls, but it seems to happen. The average age was 17.5 months. So the ages range from 11 months to 30 months, with the average, or the mean, being 17.5, so just under 18 months old. 5 of those children were admitted to paediatric intensive care at that time as well, most requiring intubation for airway maintenance. 2 of those children, little Joshua being one of them, needed a full tracheotomy. 3 of those 11 children required repeat esophageal dilation, and 2 underwent insertion of feeding tubes. On sort of digging a bit deeper, we discovered that there was one particular brand of dishwash detergent in one particular container type that was implicated in over half of those cases. So that was quite a discovery for us. And it's information, discovering information like this that allows us to actually use that information to make change. So it's a very quick sort of overview of sort of areas of concern that involve paediatric poisoning in New Zealand and what we do with that information we have. And yeah, if anybody has any questions, happy to answer them.
Thank you very much, Lucy, for that insightful presentation.